It's now my pleasure to talk about diabetes. So if we look at statin trials, and here you have results from the cholesterol treatment trialist collaboration, for every 1 millimole per liter reduction, whether patients have diabetes or not, there's a similar relative risk reduction, the same 21% reduction in major vascular events, although, of course, because people with diabetes have a higher absolute risk, as we keep on coming back to, therefore the absolute risk reduction is greater. So statins work. What about if statins are not enough? Prior to PCSK9 inhibitors, we did not have a lot of good news. Add-on of niacin, of course, did not help. Add-on of fibrates did not help. Ezetimibe, as I'll show you momentarily, modest cardiovascular benefit on top of statin, and bile acid sequestrants have actually never been tested in a clinical trial as an add-on to a statin. If we look at the IMPROVE-IT results, in fact, the patients with diabetes were one of the subgroups that showed somewhat greater benefit. The hazard ratio was 0.86 in people with diabetes, whereas in people without diabetes, the hazard ratio was 0.98. So now let's look at what was seen in the two trials with PCSK9 inhibitors. So in the Fourier trial, here you can see the baseline glycemic status. 40% of patients had diabetes, another 38% with prediabetes, so not surprisingly, in a group of patients with stable vascular disease, glucose intolerance was very common. If we look at the LDL reduction with evolocumab, you see people with diabetes on the left, without diabetes on the right. Very similar LDL reductions. If we look at the effect of evolocumab on the primary MACE plus outcome, hazard ratio 0.83 in those with diabetes, 0.87 with those without. If you look at the absolute risk reductions, 2.7% in those with diabetes versus 1.6% in those without diabetes. If we look at the so-called key secondary endpoint, the MACE endpoint, hazard ratio 0.82 in those with diabetes, 0.78 in those without, so very similar relative risk reductions, and in this case, similar absolute risk reductions as well. And one of the key questions, will we see an increased risk of diabetes in patients treated with a PCSK9 inhibitor? As you can see here, overall, there was no increase. If you look at people with prediabetes at baseline, who of course have the greatest likelihood of progressing to diabetes, hazard ratio was 1.00, so reassuring data, although of course relatively short duration of follow-up. If we look at the Odyssey Outcomes trial, they presented the data in a somewhat different way, but light purple is normoglycemia, prediabetes dark purple, and diabetes in black. You see the reductions in LDL identical no matter what the baseline glycemic status, and similar effects on non-HDL, HDL, and triglycerides. If we look at the relative risk reduction in response to alirocumab, identical whether patients were normoglycemic, prediabetes, or diabetes. Again, the absolute risk reduction was significantly greater in those people with diabetes at baseline. And again, when they looked at the effects on glycemia, no increases in hemoglobin A1C, in fasting glucose, or in new onset diabetes. So how does this translate into guidelines? Yet again, you have different guideline groups looking at the same evidence, yet coming up with somewhat different recommendations. So the American Diabetes Association took a similar approach to ACC-AHA, and again, do not have targets, but do have thresholds for treatment. The American College of Endocrinology was actually the first group to coin the term extreme risk, and they've had an LDL target less than 1.4 for several years now. Diabetes Canada, we're saying LDL less than 2, but we're in the midst of revising this, and this will be revised downwards. And again, if we look at the ESC, EASD recommendations, LDL again less than 1.4 in the very high-risk patients, defined as people with diabetes and established CVD or other target organ damage, or 3 or more major risk factors, or people who've had type 1 diabetes for at least 20 years. So in summary, statin monotherapy may not achieve targets in all patients. Previous add-on to statins are suboptimal. PCSK9 inhibitors appear to have similar efficacy and safety in individuals with or without diabetes, with no apparent adverse effects on glycemia. Thank you.